Afternoon. My name is Christian Dellis. I'm at the University of Glasgow. I'm the Honorary Secretary of the Association of Physicians, and it gives me great pleasure to welcome you all to this first event that we have in our webinar series, and it's a webinar series on emerging issues in translational medicine. Now, first of all, a few housekeeping rules or announcements. As you will have noticed, this meeting today will not be chaired by Anna Dominicak, our president. Anna has been called to an urgent meeting in her new role in the Department of Health and Social Care. Now, very clearly, the event is not about the chairperson, it's about our outstanding faculty that we have today, and you will be very pleased to hear that nothing has changed in terms of our faculty, so these are still the same. I would also like to advise that the session today will be recorded, and we will make the recording available on our website, and we are also considering to publish a podcast of this event today, so stay tuned, please. And lastly, you will have seen that the agenda today is really about short statements by our panelists and then followed by a moderated discussion. And the discussion will very much need your input. So please use the chat function or the question and answer function in Zoom, and we will try and pass your questions on to our panelists throughout the meeting. Okay, so I'm just trying to share my screen here, if that works. I hope it does. So this is the event that we're on, so our webinar series. Just a few words on the Association of Physicians. So for those who don't know it, ladies and gentlemen, obviously the ongoing COVID-19 pandemic has changed the way how we practice medicine, how we conduct research, and how we publish our research output. And the Association of Physicians has been founded by William Osler in 1907 and is really committed to excellence in translational medicine. Now, there has been a recent editorial by Trisha Greenhalgh in the PLOS Medicine journal. And here she asked the question, will COVID-19 be evidence-based medicine's nemesis? And that's pretty much the topic of today's webinar. She shows this model here, and this is a model how practice-based evidence and evidence-based practice work together. And whenever you look at such new concepts of evidence, I think it's really important to know that these new concepts are informed by our historic experiences with other pandemic or other global healthcare challenges. They are informed by the way how we interpret and publish our science, and are certainly also informed by the way how we practice medicine. And this is pretty much what we're going to address with our really outstanding faculty today, and each of them will give a very small statement and then followed by discussion. So without much further ado, I would really like to introduce my co-chair, Professor Alan Irwin. He's Professor of Dermatology at Trinity College Dublin, and our discussant, and that's Professor Colin Dayan, Professor of Endocrinology and Diabetes at the University of Cardiff, and Colin is also the Honorary Treasurer of the Association of Physicians. And in the background, you see also Claire Ford, and Claire does all the hard work, and she will put us right in case of any technical glitches. So she's at our association's secretariat. So Professor Irwin will kick off the meeting. So over to you, Alan.
Thank you, Christian, for that. And thank you for everyone who has joined online. And thank you to our panelists. So we're quite a nicely themed meeting today. So we're going to have a little bit, the start of the meeting is going to be about history and how it rhymes. And then hopefully there'll be some hope at the end of this as well. So we're going to paraphrase Seamus Heaney, when hope and history rhyme. So the history piece is going to start with a historian of the 1918 pandemic, Dr. Ida Milne. So without any further ado, I'm going to place you in Ida's hands. Thank you.
just managed to unmute myself. Hi, and thank you very much for the invitation to talk here today. It's a great privilege for historians to earwig on such events. When the Wuhan epidemic evolved earlier this year and began to spread around the world, causing widespread panic, economic and social disruption, as well as illness, I watched fascinated. As a historian of the 1918-1919 pandemic, it was seemed like having that history come back to the present. The news stories, the global society stilled by illness or fear of illness, the mass burials, the puzzle for medicine trying to come to grips with a new and frightening disease capable of causing such disruption were mirror images of my research. Many of the newspaper headlines could have been lifted straight from the pages of the 1918 press. The questions then and now came thick and fast as medicine tried to respond to this major challenge to their contemporary scientific knowledge and authority. What was it? Where did it come from? What could it be treated with? What would the long-term results be? The medical professions in 1918 had great confidence in the relatively new science of bacteriology as a weapon to at last control the infectious disease that caused society so much death and hardship. The typical number of deaths would be about double the number that we have today in Europe and America. In many countries in Europe, dramatically falling death rates fueled their confidence in the science of bacteriology. The Registrar General for Ireland, Sir William Thompson, noted in his annual report for the flu year that 1918-1919 would have seen the lowest rate of death from all causes had it not been for the Spanish flu. But here was a new disease that didn't respond to bacteriological methods. So for some time, they found it hard to accept that it actually was a flu, as they understood flu to be caused by a bacterium, probably Pfeiffer's bacillus, or HIB as we know it today, which was then believed to have caused the Russian flu pandemic of the 1890s. As Ireland went through the worst of the three waves of the Spanish flu it experienced in the autumn of 1918, there was an energetic discussion about treatment and vaccination efficacy in the national and medical press. The Royal Academy of Medicine in Ireland held an EGM on the 15th of November to pool knowledge and treatments, and that's what I'll focus on here, really to show just how avidly medicine was then, as now, attempting to learn more about perplexing pandemic disease that defied contemporary medicine, or at least for a while until they got a grip on it. George Peacock, the Academy president and a physician at Dublin's Adelaide Hospital, noted the widespread public panic about the disease, but he neglected to mention that the holding of a rare EGM indicated that medical professions were just as rattled as the public. The meeting focused on three broad areas, discussing the clinical presentations and findings from postmortems, the efficacy or otherwise of vaccines, and treatments. The post-mortem returns were fairly limited, as some hospitals had reservations about conducting them for fear of contagion and indeed banned them. William Boxwell spoke to the meeting of the PMs he did with Dorothy Stopford Price, who wrote in her memoirs about having to do them surreptitiously. She was quite a small woman, and she had to drag the bodies from the mortuary in her hospital late at night with the help of hospital porters, always afraid that they'd be caught. The vaccines used in 1918, because flu was understood to be bacterial, were made from several different types of bacteria, including usually HIB and Streptococcus. And at the RAMI meeting, Peacock described the value of influenza vaccine as a burning question at this time. Echoes again. He had used a Trinity College vaccine in a few cases, but couldn't see any particular effect after using it. John Spears, who was a doctor at the Adelaide Hospital, too, said that he began prophylactic vaccine treatments on the 7th of November 1918. He didn't favour the use of mixed vaccines of Streptococcus and Pneumococcus on people already suffering from the disease, as was common practice in other countries. They'd give them to sufferers to try and make them better. Quite a different perspective to what we have today. In his view, rigid isolation was the most efficient prophylaxis, but he thought that a vaccine of Bacillus influenzae could confirm some immunity in suitable doses. Other speakers at the meeting broadly agreed, saying that vaccines were really useless to treat those who were already ill, but that they might mitigate the severity of an attack if a patient had been vaccinated earlier. Some of the doctors spoke too of catching the disease themselves, particularly while trying out the vaccines. There was little consensus at the meeting on the subject of the correct medicinal treatment for flu. for the flu, reflecting the difficulty of fighting an unknown enemy and also the wide variety of symptoms. Peacock said he used quinine to reduce the fever and aspirin for a headache. Like many other doctors, he considered keeping the bowels free and promoting sleep to be important. He prescribed calomel as a purgative and Trianol as some preparation of opium for sleeplessness. He suggested a stimulant was necessary, and many doctors prescribed strychnine for this purpose, very James Bond, during the pandemic. John Spears used a similar selection of drugs to those used by Peacock: calomel, oxygen stimulants, salicylates, and strychnine, and he considered strict serum treatment, especially for pneumococcal pneumonia, not especially useful. But ultimately, most doctors relied on whiskey and brandy widely, both in the community and in hospitals during the pandemic. One of the doctors said that the doctors in the Mater Hospital, the older doctors in particular, gave out in what he called heroic quantities. When I was reviewing the RAMI meeting for this webinar, I could see connections between it and a WhatsApp COVID-19 group that Alan and I are involved in, which was set up by respiratory consultant Professor Oisin O'Connell, with representatives of the medical professions and others involved in managing the crisis in Ireland. The purpose being to share emerging studies, to discuss them, and to get good quality information to the public through media outlets. It's been highly effective. As the historian on the group, I've been privileged to observe medical professions making history under really high-octane circumstances, worried about their family as well as work. And knowing that background and what medical doctors undergo during such a crisis, both professionally and personally, has really opened a new lens to me about that 1918 meeting. It shows how doctors then as now react in crises like these, and probably in earlier similar scale crises like the plagues of Justinian and the Black Death, which can challenge what contemporary medicine knows. They're forced to puzzle out things at an uncomfortable speed, where they can't rely on the comfort of an evidence-based medicine when that research has yet to emerge. Thank you.
Ida, thank you so much for that. That was really excellent and really enjoyable. It sets a picture for another little bit of history rhyming, because one of the drugs that was prescribed a lot in 1918 was quinine, and we're going to hear from Haider next about hydroxychloroquine amongst others and prescribing patterns in the United States. So Haider, we're delighted that you've joined us. Thank you so much.
Thank you so much for the invitation and to be able to speak to you. As the sole American representative on this call, I almost want to hang my head in shame, because unfortunately, even though the US has been a leader in biomedical research and clinical research, in this particular epidemic, we've just not been up to task, and I feel like nothing exemplifies that more than the story of hydroxychloroquine. So hydroxychloroquine has been around for a long time, but through some unusual channels, it made its way all the way to the top of the American political food chain, initially starting with some studies that have now been highly questionable. There were some right-wing bloggers who promoted it. It made its way to Fox News and ultimately to a presidential press conference. And one of the ways that we wanted to study the impact of rampant hydroxychloroquine prescription in the United States was in fact using prescription data, using a national database and comparing how those prescriptions for hydroxychloroquine changed over the course of this pandemic. And so I'm just going to be sharing a few slides from that essentially provide a summary of those results. And this was a paper that was published in JAMA, I want to say a few months ago. And really our question was very, very simple. We wanted to see how did prescription patterns in the United States change between February and April of this year compared to how they were last year. We looked at hydroxychloroquine and chloroquine. We combined both of those prescriptions, but we also looked at some of the other major common drugs that were prescribed. We used an all-payer database that reflected about 17 million claims, and then we generated national estimates from this database. And then we essentially we weighted these data against a nationally representative database to generate these national estimates, and I'll just get into the results next. So here is the percentage increase over baseline in hydroxychloroquine and chloroquine prescription over in 2020 compared to a similar time period in 2019. And what you really see is that in the week of March 14 to the 21st, there was a very, very large surge of prescription of this medication. And this really timed very nicely, unfortunately, with a press conference that was held by President Trump on March the 17th, in which he essentially touted the use of this drug and essentially went on to say that what is the worst that can happen? What is the harm in prescribing it? And what you can see is that, unfortunately, both perhaps because of interest by patients, but also by providers, we see this huge surge in prescriptions corresponding to that week. And then we see a sort of late surge later during this week, during the study period. And then one of the other things that we did was, in fact, that we looked at prescriptions by fills. So we looked at prescriptions for hydroxychloroquine or chloroquine that were for less than 28 tablets, for 28 to 60 tablets, and then for greater than 60 tablets. Now, the reason we did this is that this is a medication that is, in fact, life-saving for patients with other conditions such as lupus or rheumatoid arthritis. And we wanted to see if there had been a change in prescriptions and chronic prescriptions that were provided to patients who may have been using it for a long time. And what you see is that the vast majority of this spike in prescriptions was driven by these short-term fills, which are really reflective of off-label use for potentially hydroxychloroquine prophylaxis. While at the same time, if you look at the orange line, which is for the long-term fills, we actually saw a reduction compared to baseline. And this actually corresponded to shortages that had been reported across the United States with patients who needed this for their indications not being able to access this medication. So not only did we expose patients, there are many, many patients to a harmful drug, we actually restricted access to patients who actually had an appropriate indication for it. And then when you put the numbers together, what you essentially come to is that over the study period, almost 500,000 excess prescriptions of these drugs were prescribed in the United States compared to 2020. And we could focus on this one drug, but really there's a larger message about what this means about clinical research and how we practice medicine. And I outlined some of those concerns in an op-ed I wrote for the New York Times. One of the things that happened in the middle of this pandemic was that the FDA actually issued an emergency use authorization for hydroxychloroquine, again, based on very little data, which to me reflects a politicization of the FDA and other public health organizations. We've seen similar trends, while that EUA has now been revoked, we've seen something similar for convalescent plasma, and these concerns are going to be even more important as we approach a potential vaccine. One of the important things that I wanted to focus on is that there have been hundreds of trials that have been dedicated to this drug based on very spurious data, and that is in fact diverted resources for potential other evidence-based measures. We've had no randomized trials about, say, things like convalescent plasma, which you could say has more of a biologic rationale. And again, I know that the UK is ahead of us in this regard. The same thing is true for anticoagulants, which are being widely prescribed. Yet no large randomized control trial data is available as of now. And the other thing that this off-label prescription does is that it in fact diminishes enrollment in clinical trials. So not only do we not learn anything from off-label prescription, but we actually know less because any of the trials that could have answered these important questions now have difficulty enrollment. And then I think one of the things that it does, and one of the, I think, reasons why this was promoted was because it was used as a diversion from other potentially politically harder decisions around social distancing and mask mandates that unfortunately the administration did never implement it. And I think the last thing, and I think which is really, I think, the major focus of, I think, what we need to be talking about further is how these efforts, in fact, erode trust of the public in the medical enterprise when they hear these mixed messages. And again, I'm so glad that we do have entities generating evidence such as the recovery trial, and Dr. Horby is here to talk about that. But as we look forward, we really need to think about the implications of exercises, such as these exercises around hydroxychloroquine, and think about how we can avoid things like this in the future. So with that, I'll end my presentation, and we'll move forward in the program.
Haider, thank you so much for that. That was very striking data and very nicely presented. And of course, your editorial was prescient in that you hadn't anticipated convalescent plasma could be potentially politicized, but many would argue that it has been, and the FDA may or may not have been compromised in that. So you were ahead of the curve there, and I'm sure you are right to highlight the vaccine issues coming up. We're going to have a longer discussion after all the presentations, and we're going to change tack a little bit now into the weighing up of the evidence. And this is to highlight an initiative that happened between Cardiff and Oxford universities, led by Katja Simon and Ewan Gillimore, with Felix Richter, the postdoc, doing a lot of the heavy lifting too. And this is about how in this panoply of papers, there's been something in the region of 45 or 50,000 papers published already. Where do you find the evidence? How do you measure it? And I'm going to hand over to my presenters now. Thank you.
I'm Awen Galimo, and I'm an immunologist from Cardiff University. Thank you very much for the opportunity to come along and tell you about our literature initiatives. So as I said, I'm an immunologist, but I normally focus on cancer research. But as many immunologists up and down the country have done in recent months, we've given quite a lot of time and thought to COVID-19. And the reasons are pretty obvious, because we, like everyone else, have had restrictions imposed on our usual day-to-day research. And we also have, of course, the knowledge and expertise that we can apply to understanding aspects of the disease. So it's right that we use this expertise to help us all, including ourselves, to get back to normal as quickly as we can. So in terms of the immunology, there are several key questions that need to be urgently addressed, and they're listed here on this slide. To answer these questions is a huge endeavour. And the questions, they're ones that we're actually still grappling with for other viruses that we've been working on for far longer. So the most obvious way of sort of doing it, of course, is to get stuck into new research projects and to apply our practical skills to the study of coronaviruses. And researchers have been extremely nimble in this regard. We've seen a lot of positive developments, from gaining R&D approvals more quickly through to the emergence of a number of initiatives, such as the one I've mentioned on this slide. This is a UKRI-funded consortium led by Professor Paul Moss in Birmingham. And this combines then the efforts of the British Society of Immunology, together with immunologists from 17 institutions across the UK. And they've all come together to try and address these key questions. So it is fair to say that COVID-19 is helping to some extent to break down some barriers to research. And hopefully this will pave a more efficient way forward for non-COVID focused work also in the future. But as well as the practicalities of the bench work, another huge challenging aspect of COVID-19, and of course an essential partner to the bench-based research, is keeping abreast of the literature. And given the sheer volume of information that's coming out day by day, how does one keep abreast of it? And secondly, how do you find the time not just to read it, but actually to form a critical appraisal of the work? And both aspects are crucial for informing the lab-based research and for making sure that what we do is do the best experiments as quickly as possible. So it's with that in mind that I'm now going to hand over to Felix from Oxford. And what he'll do is tell you about how we've tried to rise to this challenge with our literature initiatives set up both in Cardiff and Oxford, and which have now been merged. So over to you, Felix.
Thank you, Owen. And also thank you very much for the invitation today. I'm standing in here, not yet as a postdoc, but pretty much hopefully handing in my thesis next year as a representative for Katja Simon, who is originally on the program. And as Owen has been addressing a little bit, we have been trying to find an initiative in which we kind of can help physicians as well as researchers who are working at the forefront of coronavirus research to make their way through the vast literature on COVID-19 and SARS-CoV-2 and try to identify sort of like studies that can lead the way for future research that also basically discriminates the good from the bad. And I'm pretty interested later on to hear exactly what Jonathan has to say in his talk as well, who I assume will give more an insight from a publisher's perspective. When we look at the COVID-19 literature, it is very interesting to see sort of like how fast publishing is working currently in this particular context. As you can see here, I've been just plotting a couple of different types of infectious diseases and sort of like with their keywords and whether they are basically preprints or already annotated on PubMed. And you can see that despite the fact that, for instance, HIV has about the same number of preprints currently on Bio and Med Archive, we see that since the start of 2020, a lot more papers have been published on SARS-CoV-2 in peer-reviewed and probably partially non-peer-reviewed journals as well, which means that naturally for the scientists who are doing the hard labor and physicians who are in the field, it is very crucial to get a fast and quick overview about what is going on in the research world. It creates, though, also certain challenges that come with fast publishing. Naturally, there's a question of the research quality. In the beginning of the COVID-19 epidemic in particular, we experienced in our literature initiatives that there was a lot of like very short communications and with partially not yet that great of research focus. However, that has been steadily been increasing. Generally, it was also that due to the vast majority of papers being published, it was difficult for researchers to keep an overview besides doing their own research work. And lastly, naturally, it is how do we communicate these new findings to sort of like the research community as well as sort of like general public. So for this, both Cardiff and Oxford have been establishing on their own independently at this point their own literature initiatives. And first of all, to give these short digests, but also to assess critically and give an initial feedback on preprints and papers that have been published in order to kind of like give researchers a little bit more time on their own research hands and to kind of provide them some more orientation on papers that are worthwhile reading. Besides this, we have been establishing collaborations with, for instance, publishing journals, such as Nature Reviews Immunology, to kind of like distribute sort of like highlights that we have found in the preprint landscape, but also to communicate to the general public and summarize sort of like overarching topics on SARS-CoV-2 in order to kind of overcome issues of misinformation. I just want to give you a very brief insight in how we have been establishing this. In the meantime, the initiatives actually between Cardiff and Oxford have been merged in order to kind of like use sort of like a broader panel of students and postdocs in order to kind of assess the COVID research landscape. And so usually how our weeks work is that we are around the weekends kind of like are gathering all of these different new preprints and papers, are pre-processing them in order to find the ones that are particularly important for our immunological field, in order to know which ones we can actually assess and where we have our expertises. Then our engaged students and postdocs actually do a primary assessment of the paper and write a summary on it. And in particular for the preprint papers, as they have been not going through any official peer review process yet, we are usually also conducting a secondary assessment through a senior research faculty member in order to really make sure that the data we are distributing afterwards have concrete validity. And lastly, naturally, there is a huge amount of sort of like distribution that we're conducting in terms of, for instance, in Oxford at least, we have a website where we are kind of like compiling all of these different summaries where you are very well invited to kind of like look up any of the topics that you are particularly interested in. We also RSS feed to the Bio and Med Archives preprint journals in order to give direct feedback to the initial manuscripts. We do, as I mentioned, do public outreach as well, such as, for instance, about diabetes and COVID-19 in order to inform the general public a little bit more about the ongoing research and where, for instance, heightened risks of disease are coming from. And as I told, we do have these collaborations in order to highlight specifically well done preprints that we are seeing will have a great impact on sort of like the overall immunological research landscape. In Cardiff, they have a particularly interesting newsletter in which they are distributing their sort of like summaries, and which has a stronger, even more strong than Oxford focus on physicians. So I guess Arwen will be also very happy to send these ones to you if there's any type of interest coming. Lastly, I just want to mention this is a huge effort, not just, oh, sorry, I forgot. We do actually have a lot of impact with this, which is first of all that we see a lot of sort of like movement of people interested in coming and looking at these summaries. We have been in contact with the Academy of Medical Sciences as well as the Ministry of Health in order to kind of like give them feedback in order to help them create policies and sort of like help them with directing grant investments. And we have indirect sort of like impact on the research communities, whether this is, for instance, in Oxford with the vaccine development, but also, for instance, in Cardiff to different physicians and also administrational staff that kind of like really need these digests in a very quick and efficient way to understand where future sort of like research in terms of COVID-19 can be addressed too. And lastly, now to finish really up, this can be only done with a lot of people. And so I have listed here all of the contributors just to give you an impression that how many people are standing behind this in order to kind of like make the system work, in order to provide evidence-based information to the research and physicians community out there. So thank you very much.
Okay, thanks very much, Felix and Owen, for the presentation. I think that really very nicely sets the scene for the next statement, which will be given by Peter Horby. So we've heard his name a lot of times already, and I think he's well known to many of us, and even better known now, of course, as professor at the University of Oxford in his role on reporting the recovery trial. So I look forward to this, Peter.
Thank you, Christian. I'm going to talk a bit about the recovery trial, but really talk about why there seems to have been some loss of confidence in evidence-based medicine, and whether that's really justified or not. We've heard some of the problems already. One is the absolute deluge of data, and the concept that we're trying to drink from the fire hose and we can't really get down what we need. There's too much there, and it was really interesting to see Felix and Arwen's discussion of better ways to manage that. There is that there's been some policy positions taken which really don't seem to be based on any good evidence, and we heard that very well from Haida earlier. But I really wanted to talk about whether it's justified and what we can do about this lack of confidence. Let me just see if I can get the slide to work. I want to go back, and one of the things I wanted to say was the issue, which we're going to talk about later, about preprints. But whether it's the preprints that's the problem, and the amount of data, or the peer review process. We saw very early on this breakthrough: chloroquine phosphate shows efficacy in China. And if you read this letter, which was peer reviewed, there's no data in it to justify that statement. And another early treatment from the Marseille group, saying it's an open label, non-randomized clinical trial showing that, in their opinion, chloroquine was beneficial, particularly if you used it with azithromycin. But we all know the problems with these peer-reviewed papers. This was a statement by the editors of the journal that published that paper, saying that it did not meet their own standards. And there was a lack of explanation of the inclusion criteria, etc. So even the journals themselves really realizing that the quality of peer review doesn't always meet the standards it should. And obviously the one we're all very well aware of is the large-scale data, from the Miro group, published both in the New England Journal and the Lancet. Very high-level journals, should be well peer-reviewed. They weren't. there was clearly important questions that the community saw in these papers that the peer reviewers didn't, and led to this paper being retracted, which really shows you that peer review has its limitations, and actually, disseminating information to the broader scientific community is the way to really pick up issues, which is what we did. So in the recovery trial, we announced the results of dexamethasone in the press on the 17th of June, and we got some criticism for that. But we really felt that we were confident in the quality of the data, and that people should hear about it. And we were criticised for that, and it did take us some deep thinking as to whether we should do that or whether we should go through the peer review process. But we knew even in an epidemic, the peer review process is not that quick. And it took a month for the paper to be published finally. In that interim, the preprint was available. In that time, between 17th of June and 17th of July, there were over 135,000 deaths from COVID reported to WHO, which is obviously an underestimate. And if Dex had been given to those patients and it had the effect that we think it has, it could have saved 25,000 lives. And so that delay, we think, was not acceptable, and we're glad that we published it in the press. And then just today, there's now been a meta-analysis, so even stronger evidence that meta-analyzes our data with other dexamethasone and steroid data, which again validates the results that we published. And again, between the publication of the paper 17th of July and the 2nd of September, several 100,000 new deaths. Dexamethasone may have saved 50,000 lives. So really, between our public announcement and the meta-analysis, one could theorize that there could be 50 to 75,000 deaths that may not have been saved if we had waited until the meta-analysis to change policy. And this is the result of the meta-analysis, but it's pretty much showing that it is an effective intervention, and we were right. So I think it's about the quality of the science, not necessarily relying on peer review and certain processes. The second point really is that we're doing much better than we think. There's a lot of rubbish out there, and there's a lot of poor science and a lot of poor policy. But if you look back at other epidemics, and I was interested to hear from Ida about 2018, but if you go back to 2009, this is a review one of my PhD students did, looking at the trials that were registered for treatments for the 2009 influenza pandemic. So over 6,000 patients were registered to be enrolled in trials. Just over 1,200 were actually enrolled in any of those trials. And the published paper is less than 200 patients, a complete failure to finish those trials. And none of those trials reported during the pandemic, which was reasonably long. So absolutely no evidence generated in 2009. So I call the epidemic curve of ambition. Many ideas, many protocols, very few patients enrolled and no evidence. And this is what to change, and we are doing better. If you look at the randomized controlled trials published now, as of today, 8 months into the epidemic, there's now on published papers on PubMed, there's 11 RCTs, not all of them great quality, not all of them big enough, but they are randomized controlled trials. And there's several more on PubMed. So, we are doing better. We have shifted the curve. We're doing better than previous epidemics. There's still a long way to go, but we are generating evidence in a time frame to make a difference. So really, the point I wanted to make is that evidence-based medicine is fine. Actually, it's thriving and doing well, and we're learning new things during the pandemic. And I think what we're learning is we're relearning its importance. We really have to have evidence-based medicine. Otherwise, chaos reigns. And so I think the pandemic should reinforce the importance of evidence-based medicine. And it's also taught us a lesson that we're not teaching it well enough, because there's many physicians out there who are believing poor science and doing poor science. And it really was a reflection that the teaching isn't as good as it should be. And perhaps also the peer review isn't as good as it should be. And we need better systems to filter out the gold dust from the river bottom through work such as Felix and Anwin are doing. Thank you very much.
Thank you very much, Peter. I think that was very thought-provoking, and again leads very nicely to the next presentation. Just in the interest of time, I would say we move on. And our last speaker will be Jonathan Schultz. And Jonathan is Director of Journal Operations with the American Heart Association. And as such, he's really responsible for a number of the highest quality cardiovascular journals, such as Circulation Research, or Hypertension. And he has been very instrumental actually in implementing the policies that the AHA has on preprint servers and how they deal with such information. So I really look forward to this because we heard the word preprint servers quite a few times now. Jonathan, over to you.
Thank you. I'm going to share my slides. So. All right, so thanks again for inviting me to this. And just to give a little bit of background, if you're not familiar with preprints, which sounds like most people are watching, but preprints are author manuscripts that have been posted online prior to peer review and publication in a journal. So typically these are posted as open access PDFs to preprint servers that are organized around fields such as archive of physics, bioarchive for biological sciences, and recently meta-archive for medical sciences. These servers do a minimal screening for offensive, dangerous, and non-scientific content and are checked for plagiarism, but they make it very clear that they are not peer-reviewed in the traditional sense. And while the concept of preprinting articles has been around for a while in some fields, in biomedical research, it really has only been in the last 3 to 5 years it's taken off. As you can see from this slide, the monthly submissions to bioarchive, one of the larger preprint servers for the biomedical field, since 2017, submissions have increased steadily and significantly, with the authors posting around 30,000 manuscripts in 2019. And this is still, it's important to keep in mind, this is still a relatively small percentage of all biomedical articles published each year. For example, PubMed indexes around 1 million articles yearly. So, but it has been enough to force funders and traditional publishers like the AHA to adapt their policies and support the use of preprints, and not, for example, we don't consider it a prior publication anymore. In addition, even many larger publishers have created their own preprint servers and are offering options such as posting to their in-house preprint server during the journal submission process. So as everybody has discussed today, the COVID-19 pandemic has only really accelerated the trends toward rapid dissemination of research and has increased their use and prominence of preprint servers. As this chart shows, the bioarchive received a huge spike of submissions starting in March. And as you can see here, this is a combination of the bioarchive and meta-archive submissions, public posts, excuse me, just of COVID-19 research. So you can see they're publishing combined hundreds of manuscripts a week. And so this huge increase has also translated into usage and downloads of bioarchive. For example, the spike here on the right is starting in March. And meta-archive is only about a year old, but they've reported a 100-fold increase in usage this year. Another significant change is PubMed has started to a pilot to include a limited number of COVID-related preprints in their search results, which they never did before. And preprints are now regularly being discussed and highlighted in media such as New York Times and The Guardian, and are being shared on social media by researchers and the public alike. MC Hammer shared a bioarchive article just recently on Twitter. Many authors see, as basically been discussed already, many authors see that preprints are a way to kind of move past the bottlenecks that are in traditional publishing, allowing them to post their findings quickly within a few days as opposed to a few weeks or more. But they're also being used as an avenue for negative, confirmatory, inconclusive results that journals may be reluctant to publish because they don't have the time or they just don't have the space for them. But these findings are important for our understanding of the pandemic and our response to it. Of course, there have been some problems with this rapid dissemination of non-peer-reviewed research, especially towards the beginning of the pandemic, when it was, let's say, less than rigorous pre-printed research was being latched onto by political actors to make their point. And there was kind of this feeling that it was contributing to the miasma misinformation that is pervasive at times. In response, bioarchive and meta-archive both made their disclaimers more prominent and increased the level of screening for COVID manuscripts in particular, kind of inching them a little closer to actual peer review. So the question in the title of this talk is, I think it's hard to definitively say whether preprints are for good or ill at this point, because they're primarily used as a tool for disseminating and communicating science. They certainly give more power to the authors and researchers, as Peter mentioned, and thus more of the responsibility that comes with it. And that end, basically educating the public on the use and misuse of science is is likely just going to continue to be an ongoing endeavor, and preprints is just another aspect of that. Thank you.
Thank you, Jonathan. That was a succinct and excellent summary. So what we're going to do for the next few minutes is we're going to allow all of the presenters to discuss each other's presentations, if you like. If you have any questions that you would like to ask of any of the other presenters, Christian has a few questions ready from people who have said they're going to attend, and they've already pre-submitted some questions. So we'll start with the panelists first. Thank you very much.
So maybe just in the order of presentations, if we do it that way around, that could actually work. So Ida, have you learned anything about new ways?
I'm fascinated by communication and how we're talking about, like, that Haida was, you know, he was showing his pieces that he'd written for the New York Times. And I think it's really interesting that this pandemic has given many experts to the media right around the world. Scientists and doctors have had very good access to the media, and very good quality information has got into the public domain. And again, Peter emphasized that, you know, he was showing, was it the Sun, you know, that even in a red top, we're getting really good quality information straight to where it goes. And I suppose one of the things we've been seeing is the tension between the speed at which we need to learn about the pandemic and the way we as professionals behave, and the slowness that we normally proceed with. And we've seen this even within our COVID group. I think, Alan, you know, the WhatsApp group was, you know, the tension between evidence-based medicine and the need to act is there. And I think these panels have been really interesting in the way they've raised that tension.
Thank you so much. So, Haida, is there anything you would like to add to it?
I would, and I think it's been a real challenge when it comes to communicating to the public with regards to COVID-19, because, you know, I understand that everything I write might be read by a lot of people. It might affect how they make decisions, and I'm not talking about a research paper. I'm talking about an op-ed I might write. And so a recent example is I wrote an op-ed about the effect of COVID-19 on the heart, and one of the studies that I used in it has now, in fact, already been undergone a correction. This was a study that was in JAMA Cardiology, looking at rates of myocarditis in patients who had had MRIs. And I think one of the things that my suggestion to anyone communicating to the public is always have multiple perspectives. Do not base your opinion just on one piece of evidence. Just try and have as many sort of different perspectives and sort of different sources that can sort of bolster your argument, and always think twice about what you're going to say, because you never know what is going to get picked up and be misconstrued. So I think more than ever, even though I think the public is anxious, they're fearful, they're looking to us for information, and I think our responsibility to really be very, very careful about what we write has never been more important.
Thanks. I think that's very helpful. Felix and Owen, anything from you in response to other presentations?
I think, you know, just to add to what Jonathan said about the peer review system versus preprints, you know, it's really difficult to come up with the ideal system for publishing papers, and one could debate, I think, for hours the pros and cons of preprints versus peer review. But it is clear that peer review itself is a flawed system, and it doesn't fit the COVID-19 situation, because we know that it takes weeks and months sometimes to get papers through peer review for often quite unreasonable reasons. I think it's fair to say we've all had that experience. So I think the preprints have served an excellent purpose during this pandemic. And we're seeing that because we know how many of the papers we've reviewed as preprints have ended up being published in journals. We know, for example, in Cardiff, we started off at the beginning only looking really at published papers in journals. And what we realized when we merged with Oxford is that by doing so, they'd already covered all of the papers that we were now selecting. So we actually can see that, you know, by focusing only on what's come out in journals, we would actually be missing lots of studies by many, many weeks. So it has served, I would say, a useful purpose with all the caveats.
Yeah, I can only second that, really. I think it has also shown us in a way that there is a certain need of, I think, to kind of like visualize potentially a little bit more as well, that in science is not a static thing. It's not that we have one published study and it's necessarily like the answer to all of the questions that someone has been asking, but rather that science is a movable thing. There might be new discoveries, there might be new things that we learn on the way. And I think we are now, in particular with the collaboration in Cardiff, are also thinking about sort of like new ways of potentially using such things as reviews as well, where we can actually edit the reviews after they have been published, basically update these reviews according to these new data in order to try to have a sort of like live review basically online that kind of like can show that science is not just a static thing, but it actually is in a way dynamic, that there might be contradicting data published at a later time point that is refuting some or is confirming some of the data that we already know. And with that sort of like slowly and partly stabilizing sort of like what we know. And I think this is something that we, at least in our initiatives, felt very strongly about, is something that maybe we can take out of this pandemic for future research as well.
Christian, do you mind if I comment on that?
Sure.
So, I mean, I don't know whether you feel that you are performing the peer review process for us at rapid speed, and I'd be interested to know your comments on that. But I think also there just isn't time in the pandemic to have academic discussions, you know, and to say, well, it could be this and it could be that. Politicians have to make decisions. And this is what's been driving it, is that decisions have to be made, not papers published. And I think what, you know, if you like, Peter's work and others has shown is the potential role of government or funding agencies to get upstream of this and say, stop doing all of these research. This is what we need to know, and it needs to be this size, and it needs to be done well, rather than the normal setup of everybody has a go. So I'm just throwing that into the mix here to say, to what degree, I guess two questions to Felix and Owen feel that they are doing the peer review, and also more broadly to say to people, what is the role of government here to get upstream of this noise and reduce the sort of the stream of inadequately sized papers?
Thank you, Colin, for the question. Yeah, I think in terms of your first question, I do think I would not say we are probably conducting a full peer review in the sense of a classical peer review, because we're working still in a fairly narrow time frame, which means basically still that under this time pressure that we're currently at, there might be things we are missing as well. However, I think we try to sort of like direct the eyes of researchers who are currently conducting their research, or also physicians, trying to sort of like pinpoint them towards studies that they themselves can have a deeper look at, potentially with their own expertise, and trying then to basically shut out a little bit the noise of like other similar studies that have, as you may have referred to, sort of like be underpowered or be sort of like done in an inappropriate way. So I think we kind of like serving more of this part at the moment. I think there is a potential generally for the broader community outside of a pandemic situation to kind of like serve that as a peer review on a sort of like long-term, longer scale basis. But I think in a pandemic, this can be a little bit tricky, especially, as you say, there's a certain urgency, I guess, of political decisions, but also sort of medical decisions that needs to be taken care of fairly quickly and fairly effectively.
I mean, it is quite a difficult balance to achieve, because you almost need a bit of noise, don't you, at the beginning to see what emerges out of that. And if you become too focused too quickly, then you might end up going down the wrong path. So, you know, one has to explore everything, and it's the emerging patterns, I think, that are important. And that's what we're trying to capture in the live reviews that Felix talked about, that, you know, is the model we're now sort of moving towards, which is really about consolidating where we are now and keeping abreast of that in real time. So moving away from static reviews.
We're going to hear from Peter next, but I had a question really that for Peter as well as for his comments, in the sense that when we talk about preprints, don't necessarily come from the biomedical literature originally, as Jonathan has said to us, and I think there is probably an argument for preprints that deal with drugs that can be immediately applied in the intensive care unit the day after or the hour after they're published, being held to some degree of a higher rigor before they go into an archive format, different from necessarily mechanistic cell biology, which is really interesting, but which the consequences of getting things wrong are in many degrees lower than somebody immediately gives extremely sick patients them. So for example, in the recovery trial, you could look at the consort diagram, you could look at the protocol online, you could gauge the track record of the people who were involved in that. You had a lot of ancillary evidence to say, based on a newspaper or a press release. It didn't exist completely in a vacuum. It existed in the context of a group, a protocol, a properly sized groups, and so on. So you could have a sense for that. But anyway, I'll hand over to Peter next, because he did all the work on this.
Maybe I'll answer that question first. No, I think that's really important. And that's what I was highlighting, you know, the Mirror paper in New England Journal and the Lancet. It's that, you know, the peer review and publication, you know, prestigious journal, you know, it doesn't necessarily mean something's good. And also preprint doesn't necessarily mean something's bad. There's lots of other things to look at, you know, including all the things you mentioned about, is there a track record? You know, can you see the protocol? Have these people done this type of work before? Do the numbers even add up? You know, and actually we found the preprint process really useful, because we could put out the data without the month delay of publication or longer. Much of which was silly, really. You know, we spent 2 weeks arguing whether we should put a p-value in or not whether the numbers were mattered. You know, it didn't make any difference in the end. But whereas when we put out the dexanhydroxychloroquine papers on preprints, we got some very good statistical reviews. Actually, there are some groups out there who do formal statistical reviews and write a statistical response and kind of post it, and that they were often better than the statistical reviews we got from the journals. So, you know, I've become a big fan of pre-printing, but you do need a way to screen out the rubbish, and so you can focus in on the things that might be good and really spend some time on them. I mean, the other point I just wanted to bring up about the other presentations really was the politicization of science, which to me is the most damaging and frightening thing that we've seen, and is probably not new at all. You know, the Haldane principle was put in to stop politics interfering with science, but then there's a tension with actually the need to direct the science, so you don't, so you answer the questions you need. You know, and there's, you know, more than 800 RCTs and 2/3 of them are hydroxychloroquine, and that's not sensible. And so you do need a way to govern the science in a crisis, but to govern it in the right way, not so that it furthers your own pet drug or your own political ends.
Thank you, Peter. We have a number of questions that have been submitted online, and we will deal with those and get the answers back to people offline. I just want Jonathan to have a couple of minutes to.
Sure.
Because Jonathan, if I can just jump in briefly, because two of the questions may be immediately interesting to you. So one is a question about the reviews after the preprints have been published, if they should also be published and if they should go into the mainstream journals. And I wonder what your view on this actually is.
So that is specifically referring to the reviews that come from the preprint version. Yeah, no, a number of, at the AHA, we're experimenting with this too, publishing the transparent peer review process, where we publish the reviews along with the the published article. We definitely, the editors who are supportive of it definitely think that the more info that's out there, while it may not be used by everybody, the people who do need it can really use it. But one point I wanted to kind of mention, thinking about the other speakers, is, and I think this is important, like something that's being done by the Literature Initiative, is that something I hope that comes out of this is that we stop seeing journal articles or preprint articles as ends of themselves, and that it's really, it's very rare that practice or anything should be changed based on one article. And that's kind of agnostic of whether it's a preprint or a journal article, and that we need to be thinking about kind of the continuum and how all these work together. I mean, I think there was just recently last week concern around the case report, which is in a peer-reviewed journal, of the reinfection rate. And this is we're talking about one person, but it caused like a minor concern among, at least on social media. So I think that hopefully we'll start seeing, like as Felix said, the continuum of science and how these all kind of build each other, and that's kind of where we get the consensus from.
That's great. Thanks very much, Jonathan. So just in terms, I see two very critical questions as well that we may save to the end. Just one question that was submitted before we started, actually. I'm not sure, Peter, maybe you want to comment on this very briefly. There was a question about N of 1 studies. And I'm really not sure if an N of 1 study would work in a pandemic with so many thousands and millions of affected people. But there may still be information, of course, that we can learn from individual cases. So what's your view on N of 1 studies in this situation, Peter?
Well, I think that those kind of studies, very briefly, are ways to try and generate evidence when there aren't better ways. When you've got very small numbers of patients, or you've got a clear dose response thing, and that's not the case in most pandemics. So why would you do that?
I think that's a very short and snappy answer. Anybody with a different view on this? In which case, I think we have comprehensively answered this question. There was another question about, or somebody who shared a lot of their published papers, and I was quite interested in papers that were published on kind of local experience, how the local system adapted to the pandemic, triage systems, traffic light systems. Jonathan, can I ask you this? How would a journal react to such papers? Because they may be locally very interesting, but not globally. So how do you as a publisher actually decide which of these reports do you accept for publication?
Sure. Well, at the start of this, we were accepting a lot more of those publications. They were basically almost viewpoints. This is my experience based on my hospital. But we've definitely started, as we've gotten kind of further along, we've tried to move away from those. We're really kind of looking for more rigorous, more involved research at this point.
Yeah, and I think that's what we all witnessed, a lot of these short reports or reports without data. There were two questions that came in. So one, probably, if I can ask either to respond to this as a non-medic, and the question is precisely which principle of medical ethics needs to be addressed first during drug research in a pandemic. I'm not sure either if you're willing to answer this, but probably from your perspective. So which are the most important principles here?
Well, I suppose in Ireland, we've just come through a big court case related to one of the 2009 vaccines. And I suppose, to always be very conscious of the damage that it can do and not to rush the vaccine. And it's so tempting. But I think everybody's very well aware of that since there was a pandemics, that vaccine, the issues related to that. But I'm not really qualified to talk about medical ethics. But that's something that I think that would be very much in the public interest, and not to damage in any way public confidence in vaccines anymore is really vital.
Yeah. Mm-hmm. Anything from the US perspectives on this, Haider, maybe?
I mean, I think the difference between the UK and the US's response, the research response, I think does make a strong case for whether government does need to be more involved in setting a research agenda and bringing together different centers. As you know, there's this great, the incentives in academia are not always aligned with what is best for science or what is best for patients. A lot of the, and so I think having a larger body that can set that agenda and can provide the resources and bring together all these institutions has been something missing so far. But I hope that as we move forward, we recognize how much we've lost in that process, and we can learn from the recovery trial and other sort of groups that have been more successful at doing that. I think that what Dr. Horby mentioned about the politicization of science looms large, and I think it's going to stay. We're in an election cycle, and I think that unfortunately is not going to go away anytime soon. But I think that makes the onus even more so on us as scientists and academics, that we hold our course and stay true to science rather than what's just fashionable in the current news cycle.
I think that's a great statement. Thank you very much. So I will hand over to Alan in a minute, but probably, Jonathan, can I ask you another question that came in? And you as a publisher again, or as a representative of a publisher, may have thought about this, because the question is really how much of the kind of frenzy of papers that we see at the moment is really driven by personal egos rather than kind of serving mankind. And the idea behind this is certainly, could there be a way to kind of dissociate authorship from content? So maybe even anonymous papers, so that it's not about the ego who publishes, but more about the information that is in the paper. Have you ever thought about things like that?
We do, and there's definitely experiments with like blinded peer review where the editors don't know who the author is until the very end. That's very tricky. It's especially tricky when software is being published, trying to publish things quickly. I'm more skeptical from a personal standpoint that it's actually effective, because everybody knows everybody these days, and so everything can be found. But I mean, certainly I would say that we try to not consider authorship as important as I think the questioner asker is implying. And that, in fact, a lot of the stuff that was being published in the AHA journals at the beginning was really because it was an interesting or important thing. It wasn't really so much from the author. And I will say that there are definitely received. Everybody was just putting COVID-19 in their title, even if it had nothing to do with the pandemic at all, trying to get, jump on the bandwagon. But I think that while it's noble, I think that it's very tricky in practice.
Thank you. So with this, I probably hand over to Alan again to either wrap up or ask further questions. Alan?
No, I'm going to thank everybody for listening in online, for all of our panelists here. We just have one more question in from Claire Shovlin. So Claire, we'll go with your question just before I wrapped up. And this is about the dismissal of the frontline process, the people who were dealing with patients who were dying from COVID, and how to get that out, and the only goal being to save lives. And that's a sort of a cry from the heart about when we're facing patients every day and we feel that there's a crude wisdom in finding a way to disseminate that. So thank you for that, Claire. I think just to summarize, we've gone from 1918 to 2020, and it's been a fascinating journey. I think if we focus a little bit on what Peter and his colleagues did in 2020, which was different in 1918, and what Peter was able to do, obviously all of his own and his colleagues' hard work, but it sat within a framework where there was something like the National Institute for Health Research, which was available to deliver at scale and at speed. And the point really there is that we can't switch on and off biomedical, particularly clinic-facing research. It can't be switched on and off on a tap when something appears over the horizon unexpectedly. It really sits in a culture and a context of continuous investment, training, skills, regulation, all of these things. And that's all of those tools and infrastructure and landscape need to be preserved for the next, because inevitably there will be another catastrophic health event from wherever it's coming. So it's very encouraging that we are able to get evidence of high quality rapidly and to very rapidly translate that into patient care. So I'm going to wrap up now and thank everybody. If there's any offline questions, they can be submitted to the Secretariat, and we will present those to our speakers and endeavour to get questions back. But thank you again for your attention.